Welcome to the Atheist in Recovery podcast, where we talk about finding hope in recovery. And now your host, Dr. Adina Silvestri.
Hello, and welcome to episode 13 of the Atheists in Recovery podcast. And today's episode was wide-ranging for sure. My guest is Ian Hamilton, and we talk about his latest article in the British Medical Journal about prescription drugs. And although his article is focused on England's prescription drug problem, I would bet the farm, as they say, that the U.S. has a very similar problem as well. Just for show of hands, funny, right? Show of hands. How many of you have someone or know of someone who is on depression medication? Keep them up. And now, how many of you know of someone that either abuses that medication or perhaps they have been on that same medication for decades with the same symptoms, maybe slightly better, but generally the same symptoms? Oh, yeah, look at those hands. Okay. So, all kidding aside, guys, I mean, it's a serious problem. And so we do value the place of antidepressants. We value its place, but we also talk about the reasons that people become depressed and how we as medical professionals or mental health professionals can help with the issue of hope, because it's those little pills are not inoculating you from your woes. They're not making things better. Maybe they're numbing things out, but they're not making things better. And so we talk all about that. Okay, on to my guest. Ian Hamilton is Associate Professor of Addiction at the University of York. He is a registered psychiatric nurse and has experience working with people who have drug and alcohol problems. He carries out research on addiction and writes a regular column on the subject of drugs for independent newspaper. All right, here we go. Ian Hamilton, welcome to the show.
Thank you very much, Adina.
So I want to start this conversation, as I do most of my conversations, by inquiring about your spiritual background. But before we do that, can you tell the audience a little bit about you, all the way from York, England today?
Sure. I'm Associate Professor of Addiction at the University of York. So I spend my working time looking at things like drugs policy and problems resulting from drug use. So doing some research, some teaching, and I also work with teams who provide treatment as well. So that's what I do.
Mm-hmm. Good. And talk a little bit about your spiritual background, if you wouldn't mind, from childhood.
Yeah, of course. Well, I guess it will be fairly obvious why I've ended up doing what I'm doing now, because my father actually had a problem with drugs and alcohol. So for a number of years, not while I was around, but prior to me being conceived, he had a problem, and then he had an epiphany, and he became an evangelical minister. So that was my formative years, as being around him, and he traveled across the world preaching, and he also believed he had the gift of discernment and prophecy. So he traveled to Florida, to Virginia, mainly up the eastern side of the US, and then over to India and across Europe. And he believed that was his calling. So in my formative years, that's what I was exposed to, was his very strong and passionate belief in Jesus, and he lived by that belief and that passion. But he wasn't someone that you describe as, forgive the language, a Bible pusher. He wasn't someone who stuffed it down other people's throats, but he very much held that belief and was keen that others should too. So, obviously I have, unfortunately my father's passed away, and I have a great deal of fondness for him and a great deal of respect for what he believed in, but I don't share those beliefs. So I'm fairly agnostic, really, and have been since I was a teenager.
Mm-hmm. And do you remember that switch from growing up in a fairly religious household to making that switch to agnostic? Because for some people, there's a bit of a loss there.
Yeah, no, it felt like that. And I remember it really distinctly because, this was more than just saying, I'm not going back to Sunday school. This, as I say, given the strength of belief both my mother and father and their friends had, it felt like I was pulling away from something. And I still miss that. I miss that sense of fellowship, that sense of purpose and belonging in some ways, but not enough to draw me back into it. So, I obviously reflect on it, and it's not that I think any less or any more of particularly of people who have those beliefs. It's just not for me at this time.
Yeah. How did you come to do the work that you do? Can you talk a little about that?
Well, I think it was destiny, really, given what my father did, and he counseled. He obviously did it from a certain perspective, but it certainly had an impact on me. And I think without even knowing, it was where I was drifting towards in terms of work and a career, really. So it was something that really interested me, is trying to understand how people develop problems, and could I play any role in helping them? So from that point of view, it's fairly selfish. I was looking to see how I could get something out of this, as it were. So, I trained as a nurse. That seemed fairly logical, a psychiatric nurse or mental health nurse. And as the first thing I did when I qualified was went straight into the drug addiction field. So worked in a drug detox unit, a residential unit. And over a decade worked either in the community or in residential settings with people who had drug and alcohol problems. So I can trace it back, as I say, to my dad. And then, obviously, once you're an adult, you have to take responsibility. So, but I can see how it was shaped and why I had that interest. And I'm really grateful to my father and my mother for giving me that interest and that enthusiasm to kind of get involved, really, in that, rather than, I don't know, accountancy or the law or whatever it happens to be.
Yeah. So let's talk about how I came upon your writing. So I found you on the British Medical Journal. You wrote a piece on prescription drugs and how they're no cure for deprivation. And I thought we could spend some time talking a little bit about that, because when I look at your work, the other person that comes to mind is Dr. Gabor when I read your writing. And so I think that was one of the things that first drew me to you. So maybe we could talk a little bit about that.
Yeah, of course. So, essentially, the piece that I wrote for the BMJ was as a result of a government report, really, that came out just a couple of days earlier. And this government report was instigated due to rising prescriptions for drugs that people in the US will be familiar with, opiates. So prescription morphine, as well as synthetics like tramadol and so on. But also, what's interesting about this report is it included antidepressants, so selective serotonin reuptake inhibitors in the main. So things like, I don't know what the names are in the US, but in the UK we have prescriptions for depression for things, names like venlafaxine, citalopram, fluoxetine, better known as Prozac. So all those type of drugs. Now, to me, that's quite an interesting combination, to have antidepressants in amongst opiates and benzodiazepines like diazepam. You wouldn't normally associate those two classes of drugs. So that's what got me interested, really. And I reflected on it a little bit and then wrote that piece, really. So just based on my thoughts on what I thought was going on, really, and why this report painted such a clear picture of the link between the rise in prescribing of these drugs, and it wasn't just that the numbers have increased, but also the length of time people stay on these prescriptions was the other aspect. And another additional factor was they found a link between geographical areas that were socially deprived, deemed to be socially deprived, and a concentration of these prescriptions. So in other words, geographical areas that were quite affluent had a lower rate of prescribing than areas that were less affluent. So you could call it class, you could call it social deprivation, call it whatever you like. Basically, poor people are prescribed more of these drugs than rich people. That's what it boils down to.
Yeah, that's so interesting. And so it's almost like they're using these drugs in these certain class or these certain geographic areas to either soothe pain, maybe, or distract from it, or what are some things that come to mind?
Yeah, I mean, it's fiendishly difficult to be absolutely sure. I think all we can do is generalize a little bit, because we have no way of, when data on whole populations like this comes out, you've no way of separating out, obviously, person by person. I mean, the first thing to say is some people, and I join the view, would take the view that actually an increasing rate of prescribing of antidepressants is no bad thing necessarily, because it might just be that people are getting treatment which they previously didn't. So that's a possibility, is we're just better at identifying people who are depressed and ensuring they get some form of treatment, in this case, a pill. However, I don't think that tells the whole story. And the reason for that is, what this reminds me of is when I started in this field 30 years ago, the first thing I walked into and made a real impression on me was the number of people back in the 1980s and 1990s who were struggling with benzodiazepine addiction or dependency. So these were people who had been prescribed diazepam, temazepam, any other PAM you care to mention, for very similar things, for depression and anxiety. And the hangover effect was that 15, 20, 25 years on, these people were still taking these pills, and in really high doses, and struggling to reduce it. So when I saw this report on antidepressants, there was a lot of similarity I read into it compared to what was going on 20, 30 years ago. And we now know, of course, that benzodiazepines, pills like diazepam, of course, are quite addictive, and some people do have real problems with them. So that's the other aspect to this, is nobody's really looked into the dependency potential of antidepressants. And of course, if you don't look, you don't find. And I think probably what we've got here is an early indication that there is a problem, that some people are becoming dependent on these. I don't think the pharmaceutical industry has been particularly helpful. They've not provided any input into this, any data from early trials. And of course, a lot of the problems with dependency don't come to light for months or years after people are exposed to a pill. And most trials to get approval only last a matter of months at best. So a drug may well be approved and no dependency issues show up in a pharmaceutical trial, but that doesn't mean to say dependency isn't an issue.
Yeah. I know in my practice, I work with individuals that are struggling with substance abuse and eating disorders. But for the individuals that I see,
a lot of them have been on antidepressants for decades. And I think one of the reasons that they're reluctant to get off of them is because, well, it's fear. What am I going to replace this with? What if I start to feel the feelings again? That's something that comes up a lot is, I can't, I want to mask these feelings. I don't want to feel them.
Yeah, and I think the other aspect to this is if we just concentrate on antidepressants, the reason that you would be a physician would think about giving you an antidepressant is because you would present with what are called first-rank symptoms of depression. So that could be things like not sleeping well, obviously your mood being very low, reduction in appetite, unable to enjoy things, etc., etc. Now, those are symptoms of depression, but those also happen to be symptoms or aspects that are associated with dependency and withdrawal from a drug. So when it gets to so someone started in antidepressant, they've been on it a few months, and what physicians are noticing and patients are complaining of is that when those tablets are stopped or they're reduced, they're experiencing things like disruption of sleep, interruptions in their thinking, loss of appetite, loss of hope, lack of interest. Now, how do you distinguish what is due to the pill and being withdrawn and what is due to poor mental health? Answers on a postcard, please. I have no idea how you work that one out. And I don't think you can. I think it is trial and error. It's going to vary by individual. And I think the other aspect to this I'd just like to mention is I'm not sure, as academics and researchers and clinicians, we make this distinction between dependence and withdrawal. So it was apparent in this report that antidepressants were tagged with the phenomenon of withdrawal, but not dependency. Now, to me, that's perhaps at best a nuanced difference, and in some ways I see it as an irrelevant difference. Whether you want to call it dependency or withdrawal, I don't think helps the person experiencing those symptoms. So I think that's something we need to address is, in truth, we don't know whether antidepressants create dependency. What this report strongly suggests is there is a set of withdrawal symptoms that people experience. My argument would be, why don't we call that what it is? That's dependency. It's whether you call it withdrawal or dependency is just playing with words. But I think sometimes words matter. And so to say that, I don't know, a drug like Oxycontin or heroin, you experience both withdrawal and dependency, but for antidepressants, only withdrawal symptoms, seems rather odd to me.
Definitely. Right. So that's an interesting point. And so do you think that these prescription drugs are seen in the same light as cocaine or heroin?
Absolutely not. I think anything that is deemed to be coming from a trusted official route, i.e. via physician and pharmacist, we have faith in. I mean, the other aspect to this, which I think is quite interesting, is who has status in all this in terms of who do we believe? So because this is the problems people have been experiencing with antidepressants and those withdrawal symptoms is something that patients have raised. This isn't something that doctors and researchers have looked at. And I've just got a little sniff, a little smell that perhaps what's going on here is we don't view patients' experience with the same status as we do traditional research evidence. So that's why I think it's taken so long for any of this to be given attention. And it's something just to watch, see how it plays out, because we tend to hold, I think wrongly, too much faith in randomized control trials and other ways of gaining evidence, as it were, and hold that up as being the truth. And and we write off patients' experience as just being anecdotal. But the problem with that is when you have thousands of people saying something, you can't call that anecdotal. It's no longer a coincidence. It becomes something that we should listen to and take seriously.
Yeah. And so, Ian, can you tell me a little bit about the concerns that these patients are raising?
Yeah, so they, as I say, they partly instigated this report. They were saying, what you wouldn't expect to hear, or you might expect to hear the symptoms they were describing for something like heroin or oxycodone or tramadol or whatever, but you wouldn't normally associate it with antidepressants. So what they were saying is, when their antidepressants are withdrawn or reduced, they start feeling really uncomfortable. They might get very anxious. They might start getting problems with sleep. They can't think as clearly. Their appetite is gone. They lose hope. They lose enjoyment, etc., etc. So, those are more than serious kind of symptoms. Those are symptoms and experiences that can have a real impact on your life and those around you, your ability to work, your ability to maintain relationships, right down to everyday things like driving, operating machinery, doing your work. So these are things that need to be taken seriously. And I think the report, in fairness to it, recognizes that we don't yet have evidence of dependency, and even the evidence around withdrawal in terms of research evidence is fairly weak. But that doesn't mean to say it doesn't exist.
Mm-hmm. Yeah. God, that's so interesting. So if the patients are the ones that instigated this report, what does that mean for us, for the clinical individuals? How do we make sure that their voices get heard? And that might not be an answer to that.
No, I think that's a really good point. It's one thing to be talking about all this and recognize it. It's another thing to think, well, how do you apply this in practice? So I think what most physicians are good at is listening and treating everyone as an individual, hopefully. So I think it's just important to listen to what people are saying in describing the behaviors, the feelings, and the symptoms that they experience. And, we can learn from history over this. With benzodiazepines, with diazepam, when that happened 20, 30 years ago, people were being reduced far too quickly from really high doses down to nothing in a matter of weeks. And no wonder people relapsed and then went onto the black market to source drugs, because it just was too painful, too uncomfortable. So I think we can learn something from that, and just let's look at tapering doses. Let's look at providing other forms of support when people experience these symptoms to make it a bit more comfortable or less uncomfortable. So I think there's a whole load of things that physicians can do, or they can at least broker out and refer people on to other forms of support. Giving pills out on their own, we know as physicians, is not the best thing to do. The evidence is behind pills plus talking. That's where the best evidence sits. So if people haven't had access to talking therapy, I'd hope that we'd be able to recommend that and facilitate it. And just taking our time, listening, being respectful of people's experiences, even if it doesn't match what we think should be happening. We need to trust what people are saying, believe them, and go at their pace, not the pace we think they should be going at in terms of tapering a drug down, a prescription down. Go at the person's pace. I mean, be ambitious for them. Sometimes you're the only person around them who is ambitious and has their best interests at heart. But that doesn't, I think, mitigate being kind and being respectful and trusting patients as well. Too often, I think there's a subplot here of anyone who's got a problem with a drug is automatically a liar and, someone that you shouldn't trust. And I think that runs through even now in 2019. That's still the case, as far as certainly some members of the public, and I'm afraid to say some physicians and nurses are concerned. There's still that stigma attached to dependency.
Yes, I wholeheartedly agree with that. So I want to switch gears and talk a little bit about just clinical depression for a moment. And in your article, you say that for many patients, clinical depression and pain are more than a solitary psychological or physical problem. What did you mean by that?
Well, the thing that we'd all recognize with mental health is it's although it's connected to physical health, it doesn't have the same kind of presentation and way of diagnosing a problem as our colleagues in physical health. So we don't have x-rays for this. We don't have MRIs and all the rest of it. We don't have the fancy gadgets that tell us what's going on, really. So what we rely on is obviously the patient's account of what's going on in their life and collateral source of information as well. But we know that mood, affect, and levels of anxiety are molded by more than just your biochemistry. They are influenced by whether you work or not, whether you have a relationship or not, the way that you were brought up, and perhaps some the extreme, any trauma that you experienced, or even just milestones that you perhaps didn't achieve or felt you should have achieved. So a lot of this is to do with the individual's scanning of their immediate horizon. Where do they fit in with everybody else and everything else? What's their status? What's their role? Are they fulfilled? All those kind of so-called softer aspects to being human. And even, spirituality, which is where we started this conversation. So I think, given how complex all that is and the limited time, certainly in the UK, the average appointment time is 9 minutes in general practice. Well, by the time you said hello and how are you doing, that only leaves you 8 minutes to try and get to the bottom of something. So I think all I'm pointing out is something that I would imagine, or I hope most people would recognize, is that depression isn't just a genetic predisposition. It's not just the way you're born. This isn't your destiny to have a low mood. This is about the experiences you have in life. Obviously things like grief, loss of a job, being made redundant, divorce, all those life factors will affect your mood. That doesn't mean to say you need a pill to rectify them, but sometimes a pill is the easiest thing for a patient to take and a physician to offer. And it offers that kind of almost, although it's not instant, there's a perception that it is an instant solution to sometimes a very intracted, complex set of issues. And it's certainly in the UK, I don't know about the US, but you're going to find it easier to access an antidepressant than cognitive behavioral therapy or family therapy or psychotherapy. We just don't have enough in the way of talking therapy.
Right. Or if you're in that marginalized population, you don't, you may not be taken seriously, or you may not have the means, or the list goes on for the talk therapy.
Yeah, I think there's a degree of collusion going on here, without wanting to sound dramatic, between physician and patient. So if you're a doctor working in a very deprived area, you know what the problems are. There is lack of hope for that individual in terms of employment, of life opportunity. And there's also, as I say, a lack of infrastructure around health and infrastructure, so lack of access to talking therapy, etc. So what do? You're faced with someone who is depressed. The depression likely has its roots in that person's disadvantage. Why wouldn't you offer something that you think might help, even though it's not the best or optimum thing? And that thing is a pill, and it's, I think the physician knows this, the prescriber knows this, and to a greater or lesser degree, so does the patient. But if it offers some relief, then why wouldn't you do it? But of course, that's a very short-term horizon and perspective to have. I mean, I see this as political as well. We have to look at social inequality in all this, and why is it some people have this disadvantage, and why is it intergenerational? It's not just in the current generation. This is going back 2 or 3 generations through to parents and grandparents. So I think politicians and policymakers have some responsibility and a role in part of a role. It's not the whole picture, but partly have a role in turning this around so that we make sure people have access to antidepressants when they need them, but we don't over-medicate the masses due to social inequality and other aspects of life which are nothing to do with mental health, as it were, but do obviously influence how someone feels and their lack of hope and aspiration.
Yeah. Right. Well, that's probably a good place to wind down. And I have so many other questions, but we'll save them for next time.
Oh, that'd be great.
So, Ian, if you had a time machine and you could travel into the future, what would you see? What would recovery look like in the distant future?
Well, I think it's maybe not the distant future. I think we're beginning to get there. We're beginning to understand that recovery isn't a one-size-fits-all. It's not like going to, buy clothes where you get small, medium, and large. Recovery is a very individual thing. And we're beginning to recognize that. So we're recognizing it in the treatments we're offering, in the length of time it takes for people to reach recovery, and what recovery looks like. Recovery is going to look very different from one person to another. So I think that's great, and that really gives me hope. It gives me optimism for the future. I've got the benefit of 30 years in this field, and that's one of the really significant changes I've seen, is rather than trying to apply a generic one-size-fits-all, as I say, definition of recovery, we're beginning to accept that looks very different for each person, and I celebrate that. That's fantastic, because it means that people don't have to feel as though they have to fit one definition or one style of recovery. It can be very different for 2 people in the same area.
Thank you for that. What are some of the best ways to find you and all of the awesome work that you do in the community and for the medical community as well?
Oh, that's very kind. Probably on Twitter. So my Twitter handle is I can never remember what those little lines are called, but Ian little line Hamilton little line, whatever those things are called. Underscore, I think that's the word, isn't it?
Yeah.
Ian underscore Hamilton underscore. So I'm pretty active on Twitter, and I find it's a great way of finding new things out, of exchanging ideas, and just getting into some great conversations. So by all means, if you want to hook up that way, more than happy to do that.
Okay, great. Thank you so much for coming on today. I really appreciate it.
My absolute pleasure, Adina. Thanks for having me on.
Okay, bye-bye.
Cheers, bye.
Thank you for listening to the Atheists in Recovery podcast. For more great info and to stay up to date, head over to atheistsandrecovery.com.